Hello and welcome. Today we have a special guest, Dr. Denson. Welcome, Dr. Denson.
Thanks for having me, Rahul.
Absolutely. It's an absolute pleasure. Congratulations. Let me introduce Dr. Denson first. Dr. Joshua Denson, he's the medical director at Tulane University in intensive care medicine. He is a pulmonary critical care trained physician as well as a researcher. And today we are here to listen from him because very many congratulations for your the manuscript released today on JAMA on metabolic syndrome and COVID-19. So please accept our sincere congratulations for that.
Thank you.
So our next question for our listeners who are listening today is, tell us what are the main findings from your research work, which has been published as well? What are the main outcomes you looked at?
Sure. Yeah, so this study was a big collaborative study through the virus cohort with collaborators around the country and around the world. And what we looked at was the question related to, do patients with metabolic syndrome identified by a list of different metabolic risk factors increase the risk for death and ARDS in the setting of COVID-19? And before I even jump into the results, I'll kind of tell you a little bit about why did we do this? Well, I've cared for these patients for the past 2 years, as you have and others. And one of the things we've recognized, and we know that patients with obesity may be at increased risk, but also I've seen a number of patients with diabetes at risk. And sometimes when they are put together, those tend to be the patients that are most at risk. In fact, I have one I saw today who has all 4 of the factors that we studied in this paper, who's really not doing very well. But it wasn't always all of them combined or one or the other. Sometimes it would be a patient who was obese but didn't have diabetes or prediabetes. Otherwise, it may be someone who just had high blood pressure or just had high cholesterol. So what we did is we used these 4 different factors: dyslipidemia, high blood pressure, prediabetes or diabetes, and obesity, to kind of identify a metabolic phenotype. It's kind of a different criteria for metabolic syndrome, which we previously have published on in a few hundred patients, but now this study is over 46,000 patients that we originally looked at, with the final cohort being above 20,000. And basically the story take home is that it was a cohort study, and we found that these patients who have metabolic syndrome, meaning they had 3 or more of these risk factors, had a 20% increased risk of developing, of actually dying, and about 40% risk of developing ARDS. And we even looked a little bit further to see, well, maybe it isn't just metabolic syndrome having all of these criteria, but how does the risk change for each one of these criteria that you accrue? So if you're looking at this from home and you know that you're obese, let's say, what is your risk of developing dying or developing respiratory ARDS, acute respiratory distress syndrome, if you're hospitalized with COVID? Well, for each metabolic risk factor that you accrue, your risk goes from about 5 to 10% stepwise all the way up to about almost 25%. So that's a 1 in 4 chance of developing ARDS if you're hospitalized and you have all 4 of these criteria: mild diabetes, mild obesity, high blood pressure, and high cholesterol. Very common comorbid conditions in our community.
Well, thank you so much for doing that. And thank you so much for taking care of the patients as we speak in ICU. We cannot thank you and other frontline providers, but those are staggering numbers. 20% more chance of dying, and then 20% more likely to, and 40% of chances of getting ARDS, which is a deadly disease if not taken care of it as well. So what you make out of it, what is how it is adding to the burden on the healthcare system, especially, I don't think so, to our knowledge, this is the first time people have looked into in COVID-19 in this large scale of associating with metabolic syndrome. So how you see the helping the burden, or how much it is helping burdening on the healthcare system?
Well, that's the thing. It's, metabolic syndrome, it's very prevalent, not just in the South where I live, but across the country and really across the world. In the US, estimate about 30 to 40%. Down here, about 1 in every 2 people are obese. So just every one of these metabolic criteria, I kind of think of it as, are you a metabolically unhealthy person? And how does that contribute to your risk? We still don't have a lot of unanswered questions. This is kind of the first step, really validating what we and others have shown previously and tying these different disorders together. Before it's kind of, well, maybe diabetes is the problem, or maybe obesity is the problem, but we all know that these birds of a feather kind of run alike, right? And that in the sense that a metabolically unhealthy person has these common comorbid conditions. And it looks like the more you have, the increased risk you have, which is interesting for us because usually for a respiratory viral infection, right, you would worry more about people with chronic lung disease, cancer, immunosuppression, AIDS. Well, what we're showing is it doesn't seem to be those risk factors that are playing a big part in the risk of disease in COVID, and that it's actually more cardiovascular risk factors, things that would lead you to have a heart attack, not necessarily develop ARDS. And so I don't yet know if this is something specific to COVID, specific to infections, or specific to pneumonia and respiratory distress syndrome in itself. And that's something that we're hoping we can kind of add to the literature and help people risk stratify when they either become infected with a disease or get hospitalized with an infection.
You said we don't know enough, and that has been many scientists and physicians as we go into this pandemic and go through, we are finding the more we learn, more we study, the more we don't know. So we commend you on taking on this project. Quick shout out to Society of Critical Care Medicine. Look like that you were working in this space already, and then you received an award. So can you tell us more about your continuation of this work?
Yeah, so we are going to be looking at this kind of phenotype in non-COVID ARDS patients using data that's collected through the Society of Critical Care Medicine. So definitely appreciate that society and all the help that they've given myself and others that are my collaborators on this project and others. But we're trying to see if this is a COVID specific problem, or is this something that we just didn't recognize before that is present in other non-COVID pneumonia cases, non-COVID respiratory failure cases. So if you come in the hospital with flu, for example, are these risk factors giving you the same added risk that we're seeing with COVID? And that's what we're hoping to look at in our next kind of project moving forward. And some of that data collection is already underway.
Absolutely. And congratulations, second time for the grant receiving from the largest society in the world on critical care medicine, one of the 3 people getting every year. So I think that it speaks a lot to the importance of the work you are doing and you have done in this space. I was reading somewhere today, the news release which went out, it has, you mentioned that probably maybe because we may have higher number or incidence of metabolic syndrome in US, and that may explain in part our higher caseload as well as our higher mortality. That's a pretty bold statement, Dr. Denson. Would you like to elaborate further on that?
I think, like I live in New Orleans, Louisiana. All right, it's not a healthy city. We know this, and I think a large portion of our population are metabolically unhealthy. They have mild obesity, or they may have prediabetes and not know about it. Most of them consider themselves healthy, but it's a common problem. And our data, all I can say is that our data would support the fact that metabolic syndrome is nearly twice the rate as it was in COVID hospitalized patients, as in patients from other countries around the world. And so we did look at that question. Obviously, I can't say if it's cause or effect, but the U.S. is leading in both cases and deaths for COVID-19, as we have through most of the pandemic, unfortunately. And all I can say is that our data may support that hypothesis. But again, it's definitely not confirmatory. But if you have more metabolic disease, and metabolic disease is clearly an independent risk factor for both ARDS and death, it may be a possibility why our systems continue to be overrun with repeated surges.
Well said. Well said. I think we could be cautious around it, and then further studies are needed. Any takeaway messages for those who are watching today as providers or patients from your recent manuscript published today?
For me, the take home is to not ignore these risk factors. So if you have a patient and they seemingly are healthy, think about what is their BMI, check an A1C. I have a patient, another patient I have today right now with COVID-19 is someone young and has no medical history, but his BMI is 35 and his A1C, if you check it, was 5.8, meeting criteria for prediabetes, and he has severe disease. Now, would he have gotten vaccinated had he known his risk? I don't know. But it definitely, at least for us as clinicians, can recognize this pretty quickly with clinical criteria. I mean, you really don't even need to measure a biomarker in a sense. If you can at least get a history, and this will give you somewhat of a risk for them developing ARDS. And so how much observation should you keep that patient in the hospital for an extra couple of days to make sure they're heading in the right direction rather than send them home on oxygen? I'd argue if they have all 4 of these criteria, that they have a 25% chance of ARDS, you may want to be a little bit more cautious. So I think it can help us risk stratify who is going to be requiring critical care versus other types of medical care.
Thank you so much. I think that's such an important message, not only to patients, but to providers as well, that they can utilize some of the learnings from your study, expand it further, and use it as a risk stratification technique for those patients. We would like to thank you for not only being on the frontline provider, but finding a time to work on these important research projects, these important manuscripts as well. So thank you from us, from our channel, as well as our listeners. And those who are watching today, please like, subscribe, and write in comment section what you want to hear in future. We'll bring back Dr. Denson again to talk about on his journey when he keep moving on some of these projects. Thank you so much for being with us, Dr. Denson, today.
Yeah, thank you, Rahul, for leading all of this. Really, it couldn't have been done without you, that's for sure.
Absolutely.